Welcome. Thank you for joining us today. My name is Amy Sam. I am the Health Education Project Specialist at the Maxwell and Eleanor Blum Patient Family Learning Center at Mass General.
Hi, I am Shelley Freyd. I am an undergrad at UMass Lowell, interning here at the Blum Center.
Thank you. Next, I'm going over some housekeeping items with you all. Please note that today's session is being recorded for educational purposes. If you're interested in viewing the recording, it'll be made available on the Blum Center website at massgeneral.org/Blum-Center. Please note that you are in listen-only mode. Everyone has been muted so you can hear our guest speaker today. If you have any questions for our guest speaker, you may use the chat feature, which is located at the bottom of your screen. We'll have time for in the end. Only Blum Center staff and our guest speaker will see your questions. Please do not share any personal medical information or questions in the chat. If you have a personal medical question, please ask your doctor. Lastly, at the end of today's session, you'll be directed to a brief survey, which we'd like to ask you to help us complete. Your feedback is important to us as we plan future programs. Okay, so next I'm going to turn it over to Shelley, who will introduce you all today's guest speaker.
So joining us today is Evelyna Kambanis. She is a postdoctoral fellow at the Eating Disorders Clinical and Research Program at Mass General. She graduated from the University of Wyoming with a PhD in clinical psychology in 2023 and completed her pre-doctoral internship at Mass General. Her research and clinical interests primarily focus on avoidant and restrictive food intake disorder. In recognition of National Eating Disorder Awareness Week, she will be giving a talk on eating disorders. Please join us in welcoming Dr. Kambanis.
Thank you so much, Shelley. I'm really happy and honored to be here. I'm just going to go ahead and share my screen so that we can get started. Okay, does that look okay? Perfect. All right. So I thought that I would begin by just providing an overview of what we'll be going over today. So this is our agenda that I'm hoping to get through. So we'll start off by talking a little bit about eating disorder diagnosis. We'll move on to screening, assessment, and evaluation, treatment, and then finally, I'd like to conclude with some resources. Starting off with diagnosis, these are the recognized feeding and eating disorders. And today I'll be focusing specifically on anorexia nervosa, bulimia nervosa, binge eating disorder, other specified feeding or eating disorder, and avoidant restrictive food intake disorder. Beginning with anorexia nervosa, or AN, in terms of the core clinical features of this disorder, the first one that we think of when we think of anorexia is significantly low weight. For adults, this means a BMI of less than 18.5, and for children, it means a BMI percentile less than the 5th percentile. People with anorexia nervosa are unable to gain weight due to fear of weight gain or persistent interfering behavior with weight gain. So this might look like engaging in behaviors specifically intended to counteract the effect of weight gain. Additionally, patients with anorexia nervosa have this lack of recognition of the seriousness of their low body weight. They still see themselves as too fat despite their underweight body mass index, and they also experience a host of medical consequences. There are two subtypes of this disorder. There's the restricting subtype. There's also the binge eating and purging subtype. And what this looks like is, despite being underweight, these individuals are still engaging in recurrent binge eating and purging behaviors. And I'll soon go over how this differs from other eating disorders that are characterized by binge eating and purging. Moving on to bulimia nervosa. The core feature of bulimia nervosa is binge eating. And what I mean when I say binge eating is eating an objectively large amount of food in a short period of time and experiencing a sense of loss of control. So in contrast to overeating, which is common. So if we think about holidays like Thanksgiving, all of us likely engage in overeating, and that's normal. Binge eating is objectively large amount of food coupled with a loss of control over eating. So people feel as though they cannot stop or control what or how much they're eating. And people with bulimia nervosa also engage in compensatory behaviors. These might include purging behaviors, such as vomiting, laxatives, or diuretic use, but they also sometimes include non-purging behaviors such as fasting, which we define as going for 8 or more waking hours without eating anything, and excessive exercise that is intended to counteract the effects of the binge eating episodes. So these compensatory behaviors are engaged in order to counteract the effects of the binge eating episode or to prevent someone from gaining weight as a result of the binge eating episodes. The third big component of this disorder is that a person's self-evaluation is unduly influenced by their weight and shape. So when they think about the way that they evaluate themselves as a person, the first thing that they might think of, or the biggest piece of that self-evaluation, is their weight and shape. So for instance, if they were to step on a scale and the scale were, a couple pounds up or maybe even 1 pound up, this might ruin their day. So it's very focal, it's very centric, it's very important to them. And one of the distinguishing pieces between bulimia nervosa and anorexia nervosa is that people with bulimia nervosa are not low weight. They cannot be low weight in order to have this disorder. If they were low weight and experiencing the features of bulimia nervosa, that would likely mean that they had a diagnosis of anorexia nervosa with a binge eating and purging subtype. Moving on to binge eating disorder. Binge eating disorder is similar to bulimia nervosa. What makes it different is the absence of compensatory behaviors. So similar to bulimia nervosa, we still have binge eating. And again, that means eating an objectively large amount of food in a short period of time and experiencing a sense of loss of control. And this has to occur at least once per week for at least 3 months. People with binge eating experience marked distress about their binge eating, and at least 3 of the 5 features, including eating rapidly, eating until uncomfortably full, eating when not physically hungry, eating alone, or eating to the point of guilt. And once again, the reason that this differs from the diagnosis of bulimia nervosa is because patients with binge eating disorder do not engage in compensatory behaviors. So when we think about the 3 core eating disorders, they are anorexia nervosa, bulimia nervosa, and binge eating disorder. And just to highlight what distinguishes the 3, overvaluation of shape and weight is present in all 3, except that for binge eating disorder, it may or may not occur. It typically occurs in about 50% of people who have binge eating disorder, but it's not required to meet criteria for that binge eating disorder diagnosis. Binge eating has to occur in bulimia nervosa and binge eating disorder, and it's optional in anorexia nervosa. It's one of the 2 subtypes, so people with anorexia nervosa can present with or without binge eating. Compensatory behaviors, those compromise anorexia nervosa and bulimia nervosa, but not binge eating disorder. And then finally, low weight. Low weight is required for the anorexia nervosa diagnosis, but cannot occur for bulimia nervosa or binge eating disorder. Diagnostic crossover is very common in the eating disorders. And what I mean by diagnostic crossover is shifting from one diagnostic state to another. So this might look like shifting from a diagnosis of anorexia nervosa, restricting type, to a diagnosis of anorexia nervosa, binge eating and purging type, or from anorexia nervosa to bulimia nervosa, or even from bulimia nervosa to binge eating disorder. Most of the crossover typically tends to occur between the subtypes of anorexia nervosa. Typically, what we see is that patients who have been restricting for a prolonged period of time might begin engaging in binge eating. Crossover in the other direction, so from binge eating disorder to anorexia nervosa, or from bulimia nervosa to anorexia nervosa, is less common. And we have this other category called other specified feeding or eating disorder. And this is actually the most common category of eating disorders, occurring in 3.8% of females and 1.6% of males. And what this is a category to catch disorders that cause clinically significant distress and impairment, but do not meet the criteria for any of the other disorders. So starting off with atypical anorexia nervosa, as you recall, patients with anorexia nervosa have to be low weight in order to meet criteria for that diagnosis. Atypical anorexia nervosa captures individuals where, despite significant weight loss, their weight is within or above the average range. So the difference here is the weight piece. Binge eating disorder and bulimia nervosa of low frequency and or limited duration refer to all of the criteria being met for either bulimia nervosa or binge eating disorder, except that they're occurring at a lower frequency and or lower duration than 3 months. And then finally, for purging disorder, This is defined as experiencing recurrent purging behavior to influence weight or shape in the absence of binge eating. So if you think about bulimia nervosa, it's characterized by binge eating and purging. The difference between bulimia nervosa and purging disorder is that people with purging disorder do not experience binge eating. And last but not least, we have avoidant restrictive food intake disorder, or ARFID. ARFID is a relatively newly defined eating disorder diagnosis. And what this captures is individuals who avoid or restrict their food intake, resulting in 1, 2, 3, or 4 of the consequences listed here. So weight loss or low weight, nutritional deficiency, supplemental feeding dependence, or psychosocial impairment. And the way that this is different from the other eating disorders is that individuals with ARFID don't care much about their bodies. They don't experience this fear of weight gain. Oftentimes, if they're underweight, they really welcome weight gain and want it to happen. And they don't experience any body image disturbance. Instead, individuals with ARFID describe these 3 prototypical motivations underlying their restrictive eating, which can co-occur. So individuals can present with 1, 2, or all 3 of these presentations, and these include sensory sensitivity. What this describes is individuals who are particularly sensitive to the sensory properties of food, such as texture, taste, smell, color, appearance. Fear of aversive consequences. This describes individuals who have typically experienced a traumatic event related to their eating, such as choking or vomiting, and restrict their eating as a consequence of that traumatic event. And finally, lack of interest in food or eating. And what this describes is individuals who just don't particularly care about eating. They might be indifferent towards it. Their hunger cues might be particularly blunted. They might get full very easily, or they eat less volume than others. So just to quickly distinguish ARFID from anorexia nervosa, they do look pretty similar. The key difference here is this restraint category. So when we think about dietary restriction, that refers to intended and sustained restriction of food intake, which occurs in both disorders. The way that these individuals are different is because of their restraint. And what restraint means is the intention to restrict caloric intake, whether or not successful. So for instance, if someone wakes up in the morning intending to restrict a particular food group or restrict their food intake, and they're not actually successful at doing so, so that's not restriction, that would be restraint. Individuals with ARFID score significantly lower on restraint than individuals with anorexia nervosa, and that's because of that weight disturbance piece, shape disturbance piece, where individuals with ARFID just it's not a core concern for them. And actually, it precludes an ARFID diagnosis if they have body image disturbance. This is a trailer from a documentary that I thought I would share. The documentary is available on Amazon Prime, and it's called Not Just a Picky Eater. And I think the trailer does a really nice job at highlighting how ARFID differs from, potentially normative eating. So I'm going to try to play this. Let's see if it works. Okay, it looks like it's not working, but just to summarize what happens in this trailer, individuals are presented with a Cheesecake Factory menu, and Cheesecake Factory menus are very, very long. And so they're presented with this menu, and you have people with ARFID and people without ARFID who are asked to count how many things off of the Cheesecake Factory menu they would willingly eat or would be easy for them to eat. And for people who don't have ARFID, that number is usually in like the hundreds range. Most people in this trailer report numbers over 100 of items that they'd be willing to eat off of the Cheesecake Factory menu, whereas individuals with ARFID typically can only find about 3 to 5 items to eat on that large menu. So that's just highlighting just how severe this avoidant restrictive food intake is, and also quite differentiates it from just ordinary picky eating, which is developmentally normative. So with ARFID, it causes medical consequences, it causes psychosocial impairment, distinguishing it from what we might think of as just being a picky eater. Okay. I also wanted to take a moment to highlight some known disparities in research, diagnosis, and care access. So for starters, males are less likely than females to be diagnosed with an eating disorder and seek or receive treatment. Additionally, some other groups of individuals are less likely to receive treatment. These individuals include people identifying as Hispanic or Latino and individuals over age 65. We also, unfortunately, have extremely limited research for some groups, including Black and Indigenous populations, and historically also gender and sexual minorities, but research has increased in the past 10 years on those populations. So that's the overview of diagnosis. Next, I'd like to move on to thinking a little bit about screening, assessment, and evaluation. I thought I would highlight a couple of different screening instruments that could be used to ascertain whether, perhaps you or someone you know or a loved one or a patient might have an eating disorder. So this is called the SCOFF. It is a very quick 5-item questionnaire, and the letters in SCOFF, so SCOFF, correspond to the questions. So the first question is, do you make yourself sick because you feel uncomfortably full? Do you worry you've lost control over how much you eat? Have you recently lost over 15 pounds in a 3-month period? Do you believe yourself to be fat when others say you are too thin? And would you say that food dominates your life? If an individual scores yes to 2 or more of these items, they might have an eating disorder. It does not confirm that they have an eating disorder, but it might be an indication that that individual should potentially seek an evaluation to determine whether or not they have an eating disorder. And this picks up on classical shape and weight related eating disorders, which does not include ARFID. The National Eating Disorders Association also has a screening tool available on their website. I've included the link here. If you also just Google "need a screening tool," you should be able to find it. It's very short, it's appropriate for ages 13 and up, and it can help determine if it's time for support. Again, this is not diagnostic, but it can help highlight some potential resources or support options based on the way that the individual answers questions. Finally, this is a screening measure called the 9-item ARFID screen, which can be used to screen for ARFID. As the name implies, it's just 9 items. These are them. They correspond to the 3 ARFID profiles: so sensory sensitivity, fear of aversive consequences, and lack of interest in food or eating. And there are different cutoffs, but I think something to just be looking at is if you're taking this or thinking about this for yourself or a loved one, how high are they scoring? Higher scores correspond to higher ARFID symptom severity. And again, this is not diagnostic, but it can help sort of shed light as if to someone is experiencing ARFID symptoms or not. Finally, another question that I like to think about is food recall. So over the past month, what does a typical day of eating look like? And when asking this question, there are 3 areas to focus on: frequency, volume, and variety. So when I think about frequency, what I'm looking for is going for potentially 8 or more waking hours without eating anything. So in the case of this person's food right here, they have coffee and almond milk in the morning at 9 a.m. and then at 5 p.m., they have a couple of crackers and a handful of chickpeas. So that highlights that food frequency is a problem. This person is going a very long period of time without eating much. This also highlights that volume is a problem. So looking here, in addition to the frequency being a problem, we're seeing that the volume of foods consumed, is very, very low and is likely not keeping that individual full. One additional component to look at is whether variety is a problem. So are there certain food groups that are excluded altogether? Are there certain things that the person is eating every single day and is really hesitant to branch out into other food groups? These 3 questions provide a nice overview just to think about what might be true of someone. And typically when I ask this question, I'll ask someone to walk me through a couple of examples, maybe 2 examples, or what the past day looked like, or what an average day looks like. 2 additional questions to highlight when screening for eating disorders are quality of life questions. So do eating or food decisions get in the way of your ability to live the life that you would like to? And this gets at, how much time or how impairing is the feeding or eating disorder? What exactly is it causing the person to experience? And then also eating distress. So how much time, mental energy, and effort do you spend around your eating and food choices? Oftentimes you'll have people with eating disorders who describe that, it's this food noise in their head. Whatever they do, they can't stop thinking about food. They're constantly thinking about what they might eat for lunch or dinner, what they might buy from the grocery store, what they might bake. It's just something that won't ever, those food noises won't ever die down. We call that eating distress or food preoccupation. So how much time do you devote per day to thinking about food? So that's an overview of screening. So we went over diagnosis, we went over assessment and evaluation. Now I wanted to move on to the next component, which is treatment. And I thought I'd spend, quite a bit of time going over treatment. I do think there's a couple of misconceptions about eating disorder treatment. I also think that, perhaps people are not familiar with what eating disorder treatment might entail. So I'll go over a couple of the evidence-based treatments that we use for eating disorders, including some level of care components, common tenets across treatments, just to help people understand what this might look like. So how are eating disorders treatment? At the very bottom level, we have self-help. We have some really great self-help resources that are books for binge eating and for our RFID, avoidant restrictive food intake disorder. And these can be purchased on Amazon. And what these resources do is they take the treatment essentially that we'd be doing if we were seeing a patient one-on-one, and actually make it so that it's delivered via this book format. So it's self-help. Self-help can be done with or without support. What that looks like is, you might occasionally meet with a therapist, or you can implement it at home and read the book at home. Sort of a level above self-help, we have parent training. This might be particularly useful for parents whose kids are struggling with eating disorders, and the kids are, children and adolescents. And the parents might attend sessions with a therapist, where the therapist provides interventions and support and training in terms of treating or helping the child recover from their eating disorder. And I'm actually going to skip brief one-to-one treatment. I'll come back to it in a moment. But for full one-to-one treatment, what this looks like is 20 to 30 sessions of eating disorder treatment for any eating disorder. This is quite a long time, and we very recently have started looking at briefer treatment options. And briefer treatment options are 10 sessions, maybe even up to 15 sessions. So really cutting the length of full treatment in half and being able to deliver those interventions in a quicker format. And fortunately, we've seen that actually the briefer treatments tend to do just as well as the full treatments. So because we can treat more individuals using the brief treatment formats, because it helps reduce wait lists and more providers can provide care, we're thinking about kind of moving more towards that briefer treatment setting to be able to help more people. If outpatient is not suitable for someone, so for instance, if they're at extremely low weight because they have anorexia nervosa, or if they've tried to complete outpatient therapy and it hasn't really worked due to a host of circumstances, or if they're too medically or psychiatrically severe to be in outpatient care, the top two tiers of this pyramid refer to intensive outpatient treatment and partial hospitalization programs. So with intensive outpatient treatment, these can be day or evening programs. Typically, they're about 3 hours or so. So it could be 6 to 9 p.m., it could be 9 to 12 p.m. Whereas for partial hospitalization programs, those are full day programs. So you're essentially, it's kind of like going to work. It's maybe 9 to 3, 9 to 5, so longer, but you're still sleeping at home. You're still spending your evenings at home. Just one step above that is residential. Residential, you sleep at the eating disorder hospitalization program, but it's less intensive than an inpatient level of care. So an inpatient level of care is kind of the top and most severe level of eating disorder care, where people are hospitalized because of the severity of their eating disorder. Oftentimes they might receive tube feeding to help them get back on track in terms of nutrition, and if weight gain is necessary, that is what inpatient treatment is geared towards. In terms of evidence-based treatments for eating disorders, we know that specialized psychotherapy has the greatest evidence base. For adults, this is cognitive behavioral therapy, and for children and adolescents, this is family-based treatment. In the next couple of slides, I will provide an overview of what these things look like and what you might expect if you're pursuing one of these two treatment options for yourself, a patient, a family member. We do also have a couple of FDA-approved medications. These are only approved for adults. So Prozac 60 milligrams per day is an FDA-approved medication for the treatment of bulimia nervosa. And then Vyvanse, which is a stimulant, 50 to 70 millimeters per day, can be used to treat moderate to severe binge eating disorder. Oftentimes, we refer patients to adjunctive nutrition counseling. This is not required, but it can be a great resource for some individuals in terms of getting them back on track with their eating. When we see patients with eating disorders, regular medical follow-ups are critical. So we will always encourage patients to get a medical workup, get labs drawn, be followed by a primary care provider who can monitor the medical status of their eating disorder and make sure that they're safe. And then, as I said in the earlier slide, higher levels of care, such as residential treatment and inpatient hospitalization, might be required for patients who are medically unstable or patients who are just not helped by outpatient treatment. Okay. Moving on to family-based treatment, or FBT. So again, this is the leading treatment for children and adolescents with eating disorders, and it involves the whole family. The basic principles of this treatment is viewing the eating disorder as a developmental setback that the parents must intervene on to interrupt symptoms that the patient cannot control. It occurs in 3 phases, typically over 20 sessions. In phase 1, the parents refeed the child, or they begin to interrupt restrictive, binge, and purge behaviors. For this phase of treatment, the parents are solely responsible for feeding their child. So oftentimes, parents actually have to take a leave of absence for work. They have to accompany children to school. They're responsible for plating and serving all of the meals, essentially removing all choice and eating decision-related autonomy from the child temporarily in order to help intervene on the eating disorder. Children oftentimes don't like this, but part of moving to phase 2 is that the child has gained some, they're more accepting of this phase of treatment. And so when we transition to phase 2, the child transitions to eating more independently. And this is certainly not, the child is eating on their own 3 meals, 3 snacks per day, but rather the parent might provide 2 equally calorically dense snack options and have the child choose between one of the 2 options. Or the child might go to dinner at a friend's house, and the friend's parents will report back to the child's parents how that dinner went and how much the child was able to eat and how much support they needed during that meal period. So phase 2 is really about transitioning the child to eating more independently. Then stage 3 is really when the child returns to normal development. So this is the child goes back to eating the way that they were eating before the eating disorder, depending on what the autonomy was like before the onset of the eating disorder. The child will typically return back to that. And then the family will also tackle any adolescent issues that have come up because of the eating disorder. Clinical trials of this treatment suggest that approximately 50% of patients will fully remit after family-based treatment for the eating disorder. So just to summarize, this is a treatment for children and adolescents with eating disorders and involves the whole family. I did mention the parents, but siblings can also be involved as a source of support to the child, and the whole family is working together. This photo here, for session 2 of FBT, it's a family meal. So we invite the family to come in to the clinic and bring food to feed the whole family and offer suggestions for how to help the child that's struggling with the eating disorder navigate the family meal. So again, it really just includes the whole family. Now I'll move on to thinking a little bit about cognitive behavioral therapies for eating disorders. And I'll go into specific types of cognitive behavioral therapies in a moment. I just wanted to provide a couple pieces of overview. In terms of common tenets across cognitive behavioral therapies, psychoeducation is a really big one. So teaching patients and families about the eating disorder, about ways that the eating disorder is affecting their life, about, why someone who is restricting might later go on to binge eating, and how emotions might affect eating. A really big component is regularizing eating. So this is sort of step 1 of all eating disorder treatments, is eating 3 meals and 2 to 3 snacks per day as a means of regularizing eating. So whether or not you're hungry, you stick to this eating schedule and you eat by the clock every 3 or 4 hours. Typically, we'd prescribe something like breakfast, a morning snack, lunch, an afternoon snack, dinner, and an evening snack. So 3 meals and 3 snacks. Typically, we encourage 3 snacks for patients who are needing to gain weight and 2 snacks for patients who do not need to gain weight. For weight gain, we prioritize volume before variety. So eating preferred foods at higher volumes rather than expanding into different types of foods. This really helps with weight gain, particularly say in the case of ARFID. Patients with ARFID, they have really selective food preferences. A child might love ice cream and not much else. In the case of that child, we would tell that child to eat as much ice cream as they possibly could to aid in weight gain, rather than telling the child, oh, if you like strawberry ice cream, maybe you could try some strawberries to improve your variety. That's something that probably won't help with weight gain at the outset. So we'd save that for later on in the treatment and really hope that they're prioritizing volume. So increasing the volume of the preferred foods that they're eating. All cognitive behavioral therapies for eating disorders include exposure to feared and avoided foods and eating-related situations. I will talk about one of these exposures in the subsequent slide, and we can think about what an exposure might look like for a patient to trying a feared food. So if someone has a feared food, something say like a dessert that they're really scared of eating because they're afraid that eating that dessert would cause them to gain weight, there are some things that we can do to help intervene and challenge that hypothesis that the patient has about the effect of food on their body weight. We also expose patients to factors maintaining their body image disturbance. We use urge toleration to promote decreases in binge eating and purging. And maintenance planning is the final really big component of cognitive behavioral therapies. So at the end of each treatment, we'll take some time to think about, what were you able to work on over the course of this treatment? How was it helpful? What skills did you learn? What might indicate that a setback is coming? And how might you intervene on that setback at home on your own in the absence of a therapist? So really setting the patient up for success outside of the context of treatment once the treatment has ended. Weekly weighing. This is a really big component of cognitive behavioral therapy for eating disorders. And what this means is weighing the patient once per week in session and sharing the patient's weight with them. This is seen as a non-negotiable aspect of cognitive behavioral therapy, and many therapists in our clinic here at MGH won't proceed with the therapy if the patient is not willing to be weighed once a week. And there's a couple of really important reasons for this. So first and foremost, of course, it allows for weight monitoring, which is necessary. And when people need to gain weight, this allows the patient to see how much weight they're gaining. Oftentimes, at treatment presentation, we're presented with 2 different kinds of eating disorder patients that have classical eating disorders. This isn't so much true of ARFID, but either we see patients who are weighing far too frequently, so several times per day, maybe once a day, every day, and then like 5 to 10 times per day after that. So almost obsessive about their weighing. And then we have the flip side of that, avoidance of weighing, which refers to patients who hate knowing their weight, prefer to be weighed backwards if they have to be weighed for a medical purpose. And this represents something that is extremely distressing to them. In the case of people who avoid their weight, this is, of course, a really challenging intervention to implement. But we find that when we provide the rationale for why we do it, patients they become okay with doing it, and they actually enjoy doing it because they've learned things about their weight that they wouldn't have otherwise known. So the reason that this is done is to address what we call the broken cognition. And what the broken cognition refers to is the belief that eating any amount of food will result in disproportionate weight change. So oftentimes, for instance, you'll have patients who say, I can't eat X dessert, 1 slice of cake or 1 brownie or 2 cookies, because if I eat that amount of cookies, I will gain 3 pounds. With weekly weighing, we test those hypotheses. So for instance, a patient might come in and they might say, if I eat 5 cookies, I'll gain 2 pounds. What we'd assign them to do is eat 5 cookies every single day for the next week so that we could see what happens to their weight. They're asked to not weigh themselves at home, so they weigh themselves during the session at which that intervention was delivered, and then they'll weigh themselves the following week when they come into session. They will have eaten, 5 cookies every single day. They'll step on the scale and will be able to actually test what they thought was going to happen versus their actual weight. So looking at the discrepancy between their predicted weight versus their actual weight. Over the course of treatment, typically patients get better at predicting their weight, and they learn that the feared consequence, so it's that eating 5 cookies per day, is probably likely not going to result in the suspected weight gain. And that then removes that weight or knowing your weight or stepping on the scale as a feared stimulus. And people become more neutral towards it, which is what the goal is here, is for weight to not have that major of an influence on people's attitudes towards themselves and their bodies. For patients who are underweight, the physician that is monitoring them medically should always determine the healthy target weight. And they typically base this on their sex, age, and prior weight history. For patients who are underweight, which is a BMI of 18.5 or lower, we're typically almost always shooting for a BMI greater than 20. In all of the eating disorder treatments, patients are expected to gain 1 to 2 pounds per week. And this might include incorporating 500 calories or more per day. So eating 3 meals and 3 snacks per day, regular eating, might do this depending on how much the patient was eating beforehand, increasing their portion sizes, introducing energy-rich foods, and even considering high energy drinks if needed. So something like Boost or Ensure, which are nutrient shakes, can be incorporated to supplement the patient's eating. Okay. In terms of regularizing eating, so again, what this means is eating by the clock, 3 meals and 2 to 3 snacks. 2 snacks we introduce when we're aiming to shoot for weight maintenance, and 3 snacks will encourage for gain. Patients should be eating every 3 to 4 hours, and oftentimes programming reminders in their phone can help. Some patients with eating disorders just don't think about eating. They're not used to it, especially for people that had the ARFID lack of interest profile. This might be something that doesn't even cross their mind. So having those programmed reminders on their phone might really help them remember. And just as a reminder, we looked at food frequency, volume, and variety. And here are the things that we would do to address each one of these components. So to address frequency, you eat by the clock rather than by hunger and fullness cues. Oftentimes, patients with eating disorders want to get back to eating intuitively. And this is something that we can't do in eating disorder therapy because patients with eating disorders typically can't trust their bodies to provide hunger and fullness cues. And by going by the clock and eating regularly every 3 or 4 hours, you're encouraging your body to get back into that regular pattern where you can actually learn to trust your hunger and fullness cues. But for the beginning of treatment, this is something that kind of has to be ignored, and patients have to be eating by the hour rather than by how hungry or full they're feeling. In terms of volume, increasing the volume by adding at least 500 calories per day to support that weight gain rate of 1 to 2 pounds per week. And this is also supported by in-session food exposures. And I'll talk about what that might look like in a moment as well. And then finally, variety. So expanding dietary variety with food exposures, but always will address frequency and volume before we get to variety. Volume is, again, the most important for when patients need to gain weight. In the next couple of slides, I'll highlight 2 additional treatments. The first one is cognitive behavioral therapy for adults with eating disorders. And the second will be cognitive behavioral therapy for children and adults with ARFID. Just take it. Okay. So cognitive behavioral therapy for adults with eating disorders, this is one of the new briefer protocols. So this particular treatment, the book that's depicted on this slide, is a 10-session treatment, and it was adapted from a 20 to 30 session treatment that is still used for eating disorders, but this just makes it so that we can see more people, and more people are able to get off the wait list, and treatment is shorter, and people usually experience the same amount of treatment gains over the shorter period as they do the longer period treatment, which is awesome. So the basic principles of this treatment are that dieting maintains eating disorder symptoms. So one of the non-negotiables of this treatment is that patients cannot be dieting for weight loss. That is incompatible with this treatment, and we'd ask patients to put weight loss on hold until the conclusion of this treatment, in which case we could potentially revisit it as a conversation if it still remains an issue. Oftentimes we find that by addressing the body image concerns that the patient has, they no longer wish to lose weight after treatment has concluded. But in order for this treatment to be successful, a patient cannot be be dieting. So if they express interest in dieting, we'll probably say, you know what, seems like this isn't the right time for this treatment. Definitely come back when you're interested in pursuing it and can put off dieting for the time being. Normalization of eating pattern is crucial. So this is the first component of this therapy. It's a 10-session therapy. A good portion of the early sessions are spent normalizing eating patterns. So oftentimes we'll sync up with patients using an app that they have access to on their phones and I have access to on my phone. And we'll ask patients to log every single meal and snack that they're eating so that we're able to see what their daily eating looks like and where they might implement changes to help reach the goals that they've set for treatment. CBTT includes 5 stages occurring over 10 sessions. So for stage 1, early dietary change and exposure. So I mentioned the food-related exposure with eating 5 cookies every single day to test the prediction that that will make the patient gain 2 pounds. We would take a list of any feared food that the patient has. We'll ask them to bring that into treatment, and we'll work on challenging every single feared food on that list. So for instance, if potato chips are another feared food, on a separate week, on not the cookie week, we would have the patient eat a bag of chips every single day and ask them what they think will happen to their weight if they successfully incorporate that experiment, and look at the result of their actual weight compared to the predicted weight to be able to correct any misconception that they might have about the effect of that feared food on their body. And stage 2, I kind of already highlighted behavioral experiments relating to food. In stage 3, we conduct exposure and cognitive restructuring related to emotions. So this is where we really start. We've ruled out dieting and fasting and restricting as leading to problematic eating patterns. So now we can actually attend to emotions. So addressing any kinds of emotions that are preceding eating episodes. We'll then start to talk about body image. Body image, we typically conduct experiments. So for instance, one such experiment for a patient who, makes a lot of comparisons between their body and other people's body. And they find that they can't stop making these comparisons. Anytime they see someone on the street or any of their peers, they just immediately are inclined to compare their body to that other person's body. A behavioral experiment might look like doing 3 days where you're not engaging in any body comparisons whatsoever, and 3 days where you're consistently comparing yourself in the way that you typically do, and taking note of how you're feeling after each one of those days and talking about the differences in the way that you're feeling based on whether or not you're comparing yourself to other people. So it's just one example of what we might do for a body image experiment. And then stage 5 focuses on relapse prevention. So planning for the future, thinking about skills that were learned as part of this treatment that the patient wishes to continue working on, or what might signal to them that a relapse is coming, how they might address that relapse at home. In terms of research on CBTT, clinical trials suggest that approximately half of patients will remit after CBT. Okay, moving on to cognitive behavioral therapy for ARFID. This was actually a treatment that's created by our team at MGH. This is a flexible and modular treatment for children, adolescents, and adults with ARFID, ages 10 up, that comprises 20 to 30 sessions over the course of 4 stages. In stage 1, psychoeducation and early change. This includes changes to eating, so increasing the volume of preferred foods or making very, very tiny changes to variety if weight gain is not a concern. So what this might look like is if a patient with ARFID is only eating, say, Yoplait yogurt, and it's always strawberry flavor and they can't eat a different kind of yogurt, a very minor change to variety would be trying for either a different flavor of Yoplait yogurt, which is the preferred yogurt, or a different brand of strawberry yogurt. So again, super minor, nothing big, nothing like, oh, you've never had tomatoes, let's have you try tomato. We'll do that later on in treatment. In stage 2, we plan for treatment. So thinking about nutritional deficiencies and what foods the patient would be willing to learn about in treatment. Stage 3 is really the heart of treatment. And this is where we address was really excited to talk about stage 3. Stage 3 is the heart of treatment, and it works on addressing maintaining mechanisms, so exposing patients to avoided food and eating related situations. And then stage 4, once again, focuses on relapse prevention, similar to the other treatments that we've seen. CBT-AR is offered in two formats. So we offer family-supported CBT-AR for patients who are younger than 16 or patients who are underweight. And individual CBT-AR is offered for patients who are older than 16 and who are not underweight. If you recall from earlier, there are these three maintaining mechanisms for ARFID. So sensory sensitivity, this refers to, again, patients who are really sensitive to the sensory properties of food, so texture, smell, taste, appearance. The patient will select foods that they're willing to learn about as part of the treatment. And then we'll assign them to learn about 5 new foods per session using their 5 senses. So really taking the time to explore the foods that they bring into session. And they are required to bring 5 new foods into session every single time. And over time, we're hoping to move from tasting foods to taking tiny little bites of food, which is what we'll do when we're initially trying to learn about the foods, to incorporating full portions of that food over time. For fear of aversive consequences, these are people who typically avoid or restrict their eating following a traumatic event, such as choking or vomiting. We'll have them create a fear and avoidance hierarchy of food and eating related situations. So if you think about, a scale of 0 to 100, where 0 is foods that cause no distress or anxiety whatsoever. So for instance, for someone with a fear of aversive consequences presentation, this might look like soft foods that don't have a threat of choking on them. So maybe applesauce is a food that is 0. And for a food that's in 100, this would likely be the food that they actually choked on. So perhaps it's a piece of meat that has a bone in it. Perhaps it's a fruit that has a pit in it that was choked on. And we'll have them fill in all of the different stages between 0 and 100. And we'll conduct gradual in-session exposures to items on this hierarchy. So starting with the foods that are not at all scary, moving up to the foods that are, a 10, slightly scary, but nothing too crazy, moving all the way up to exposing them to the actual feared food that they might have experienced their choking or vomiting incidents on. Then finally, for lack of interest in eating our food, we'll conduct interoceptive exposures to help patients kind of listen to their bodily cues and increase their tolerance of fullness sensations. We'll also encourage increased consumption of preferred foods. So I think I gave the example of ice cream earlier. If a patient's not really interested in food except for ice cream, they really look forward to ice cream, but they could never care about like any other food, they're feeling pretty indifferent, we just get them to eat more ice cream. So really thinking about what foods are bringing them joy, what do they like about those foods, increasing the consumption of those preferred foods, and then potentially also eventually branching out to new foods. So that's CBT-AR. That concludes the treatment component that I was hoping to talk about. And then I'd like to just conclude by sharing a couple of really excellent resources that might be helpful. So starting off with Feast, this is an excellent resource for parents and families. This offers a global community of support, education, and empowerment for families of people who are affected by eating disorders. And there's actually this email address that you can use to reach an experienced parent who can help you find resources. They can't offer treatment recommendations per se or any sort of like medical advice, but they can listen to concerns and help point you to resources and peer support. And then there's also Feasts Around the Dinner Table Forum, which is a moderated online forum for parents and caregivers of eating disorder patients, where parents and caregivers can post questions and they'll be answered by members of the community. If this is relevant for you, I'd highly encourage checking this website out. It has a host of really excellent resources. Next, I just wanted to highlight Massachusetts Eating Disorder Care. We're really fortunate living in the state that there are quite a few eating disorder treatment centers around, starting with, of course, the Eating Disorders Clinical and Research Program here at MGH. Then there's a couple of residential and inpatient hospital programs, as well as, of course, this Need a Treatment Finder. So if you go onto the National Eating Disorder Association website, there's this actual map where you can see all of the eating disorder treatments providers in any state, really. It is up to individual providers. So if they're not working with, say, like a big hospital, it is up to individual providers to register for this website, but you'll often see like standalone providers that work in the community that have signed themselves up to be found using this website as an excellent resource. And then finally, our team here at MGH has ongoing research studies that you can find through the Rally website, so rally.massgeneralbrigham.org. We're recruiting all sorts of patients with eating disorders as well as healthy controls, so patients without eating disorders. And I just posted all the links here, but if you search eating disorders on Raleigh or ARFID or anorexia, you will be able to find these research studies. That concludes my presentation. My email address is posted here. Feel free to reach out if you have any questions. Thank you.
Thank you so much. We are now at the end of the session. If you have any questions for Dr. Kambanis, feel free to enter them in the chat. We have a question whether there are online tools to self-assess for any of eating disorders.
Really great question. Yes. So the NEDA screening tool, the NEDA screening tool, if you just Google search National Eating Disorders Association screening tool, that tool is available for ages 13 and up. But based on the way that you respond to those questions, you'll be able to see, whether your symptoms are concerning, whether you should be seeking resources or help or an evaluation for a potential eating disorder. Importantly, diagnosis by a trained professional is really important. So don't take anything that the internet says as like proof that you have an eating disorder, but rather take it as like suggestion that you should receive an eating disorder evaluation.
Thank you. And do you find that patients are accurate and honest with screening tools, whether it be self-assessment or given by a provider?
That's a really interesting question. I think when patients get to the point that they're being seen by a provider, with a couple of exceptions, for instance, a child who's brought in by their parents and who really just doesn't want to be treated for the eating disorder, they might be inclined to be dishonest. But in that case, we would also take the parent's collateral report and see how the child's responses are different than the responses that the parent is providing. For older individuals, typically they'll seek out treatment on their own. So this is something that they're interested in doing, something that they're motivated in doing. And so they tend to be honest in terms of highlighting their symptom severity and the things that they are struggling with.
Thank you. And I do see a question or request about adding the link in the chat to the screening tool, and I'd be happy to do that.
I actually have it readily available. I can just send that right now.
Perfect.
Perfect.
And then I have a question regarding refeeding syndrome. Would you be able to share a little bit about that, including how do you address it and whether you've seen refeeding syndrome happen while receiving non-inpatient intervention?
Yeah, so I'm really lucky that I haven't seen this because oftentimes when someone is at risk for refeeding syndrome, I won't see them. I'll refer them to a higher level of care because it's really scary and they should be under the medical supervision of a higher level of care. So residential or most likely an inpatient hospitalization program. So unfortunately, I'm not entirely sure how to answer that question just because I've never had to deal with it. But I'd be happy to find some resources and I could share those with you and maybe you could send those out, Amy.
Will do. Thank you. Can you share your thoughts on vegan, vegetarian lifestyle and restrictive eating? When should a parent be concerned?
Another really great question. I think oftentimes, sometimes patients will use vegan and vegetarianism as a way as a crutch, right, as an excuse to be limiting their food intake, in which case I'd be interested in exploring why they're vegan or why they're vegetarian. So oftentimes people who are vegan or vegetarian state things like ethical concerns about the treatment of animals, or, they might love animals so much and have animals of their own and just like can't deal with the dissonance of also eating animals. And then there's also a group of patients who goes vegan or vegetarian for health-related reasons. And that's the reason that I would be most interested in exploring with a patient that has an eating disorder. So some questions that I might ask include, how would you feel if you couldn't eat the way that you want to eat? So if you had to eat regular cheese, or if you had to eat a piece of chicken for whatever reason, how would that make you feel? How much distress would it cause? And if it's very clear that they're very agitated or distressed at the prospect of having to do that, and it seems that it's more for health reasons than for like ethical or treatment of animal reasons, that's when I'd be concerned. I think patients with eating disorders can go vegan and vegetarian and have it not be related to their eating disorder. So I think that's definitely a possibility. But for the subgroup that's doing it for health reasons, that's where I'd really want to parse apart exactly why they're doing it and what are the health reasons that they're concerned about.
Thank you. And are eating disorders generally screened as part of primary care wellness visits?
Yeah, I think we're generally getting better at that. Oftentimes we find that providers won't ask the questions unless the patient is giving information that would lead to them asking those questions. So I'm not sure that I think at MGH, we do a pretty good job of that, but I think, other care centers might only be screening if there's reason to screen rather than just asking it as, baseline question. I think in most like child well visits, children are asked about like depression and anxiety. I don't think that eating disorders are regularly a part of the cluster of mental health related issues that one's being asked about.
Thank you. And is there a difference between disordered eating and eating disorders?
Yeah. So disordered eating and eating disorders is tricky territory. So when I think about disordered eating, I think that someone may or may not have an eating disorder, depending on the severity of their disordered eating and how much impairment that's causing. So, if it's not getting in the way of their life, and if it's not causing issues, if they're not engaging in eating disorder behaviors such as fasting or vomiting or binge eating or laxative use, um, you know, I I would encourage an assessment, but I'd probably not be too confident that that's a full-blown eating disorder. So disordered eating can mean eating disorder. It can also not mean eating disorder, but all patients with eating disorders do have disordered eating. I hope that's helpful, and sort of parsing apart the two, but definitely thinking about how's their quality of life. Are they thinking about food all the time? What are the behaviors they're engaging in? Has anything happened to their weight as a result of these behaviors? Those are things that might really be a red flag for disordered eating above and beyond disordered eating itself.
Thank you. What are your thoughts on medications such as Ozempic for weight loss for someone with an eating disorder?
Another really great question. I am not super well versed in these weight loss medications. Of course, I know that Ozempic, which is a weight loss medication, has been rising in prevalence lately. My personal opinion is that if you're in treatment for an eating disorder, weight loss should be on the back burner. Of course, I have had patients who complete eating disorder treatment. They're regularized their eating behaviors are normal, and they still really wish to lose weight, in which case we can certainly have that conversation and explore why and how they want to lose weight and make sure that there isn't a resurgence of eating disorder behaviors once they start to healthily lose weight. Unfortunately, a lot of patients develop eating disorders as a result of attempting to diet or attempting to restrict. That is a pretty common pathway. So if someone's recovered from an eating disorder or if they're working on it, I would want to make sure that their symptoms are under control, that they're not binge eating, they're not restricting, and then think about how to healthily pursue weight loss. And in that case, I would refer. I would never do that myself, just because that's very much outside of my comfort zone as an eating disorder specialist. That something like the MGH Weight Center or another community provider that is more specialized in, healthy weight loss practices would be able to do. And I leave prescription of the weight loss medications up to them too. So that's something that I wouldn't myself necessarily do, other than to say, please hold off on weight loss until the end of treatment. Once we get to the end of treatment, we can rehab that conversation and see where you're at.
Thank you. You had mentioned family-based treatments. For this, is the child's pediatrician or healthcare provider generally involved in this treatment method?
Yeah. We would require medical monitoring, and we would correspond with a child's regular care provider to provide updates. For instance, we'll almost always reach out to set a target weight range because the provider, oftentimes the pediatrician, will have growth charts and we'll be able to do that. And then we will update on progress. So we encourage medical monitoring. Patients should be seeing their physician regularly, but they're not like they won't come to sessions unless, maybe there's a need for one session to include the pediatrician. That's not typically something that we do as part of family-based treatment.
Great, thank you. So I think we're about at time. Before we end today's session, do you have any final thoughts you'd like to share with the audience?
I don't. This was really great. I'll put my email address in the chat in case anyone has any lingering questions. I'd be happy to answer those. And thanks for being here.
Do you mind entering that in the chat one more time?
Yeah, of course.
We have a follow-up question regarding screening tools. I don't know if you have a moment to address this. If there is another tool besides BMI that's used for tracking progress during treatment. So sorry, not screening, but treatment.
Yeah. BMI is a really flawed measure. Unfortunately, weight gain is what we rely on. So we're looking at weight changes. It's not necessarily BMI that we're looking at, it is weight. And BMI, you know, is part of the calculation for gaining weight and for being underweight, but we won't typically look at something more comprehensive that analyzes fat and muscle and anything like that. So it is a reliance on weight with a recognition, which we share with patients. We share with patients that, like, you know, this is a flawed measure and it's just a number on a scale, and it could fluctuate based on a large host of factors, and it might not be the most accurate reflection of anything. So we're very open about that, but we do use weight.
Thank you. And we have a question regarding the recording. It is being recorded. I'm going to enter that in the chat. So if you'd like to visit the Blum Center website at massgeneral.org/Blum-Center, it'll be made available within, I would say, a week or two. So check back. All right, everyone. So I think that's all that we have time for. Thank you so much, Dr. Kambanis, for spending the hour with us.
Thank you for having me.
Thank you.
And for everyone who joined today's session, thank you so much. Hopefully you found today's session helpful. And I think that's it. Have a lovely rest of the day.
Thank you.
Bye.